Good morning, everyone. My name is Matt Hayes. I am a paramedic with Onslow County EMS. Today, I will be doing a presentation on damage control resuscitation. What that will involve today is it will take you through all the steps of how to do damage control resuscitation when you have that severe trauma in the field. The basis of it is I'm going to go over some things on a way that you can get the patient stabilized and get them to the hospital safely so the trauma surgeon can perform to hopefully save the patient's life. All right, so today's objectives. We will be defining damage control resuscitation in the pre-hospital setting, which I already somewhat explained. We will describe the goals associated with proper pre-hospital resources, outlining the proper steps to ensure adequate damage control resuscitation. And we are going to identify the roles of team members for EMS and fire for damage control resuscitation. And then I have two case studies from actual calls that I'm going to go over that involve trauma resuscitation. Okay, so damage control resuscitation. It is defined as damage control resuscitation aims to limit blood loss and prevent coagulopathy by combining hypotensive resuscitation and early airway control and early balance use of blood products and other hemostatic agents. And we will go over all of our different tools that we use in the field for this. Okay, so our goals of damage control resuscitation. First, what we want to do is we want to restore. And what that is you want to restore your homeostasis and adequate perfusion. So when people have severe trauma and they have blood loss, they're very hypoxic. They're not getting oxygen to any of the tissues, which with that could be your leading cause of your death. So if you're not restoring that normal balance and getting back to your homeostasis stage, then that right there is one of the leading causes of death after severe trauma. So once we go from the start of the call to the end of the call, as long as our main goal is trying to get back to a nice balanced state, also called homeostasis, the patient's outcome and survival rates go up tremendously. We want to reduce shock and coagulopathy. And some basic ways of reducing shock are, for example, once it happens and you get to the patient, remove clothing, make sure they are staying warm with warm blankets, and that's when you can also start getting into your further treatment of your IV, minimal IV fluids, because with the coagulopathy, what you're ultimately trying to do in trauma is you are trying to clot the blood and not break it up. So when people tend to give normal saline too much of it while you're administering blood, everything you're doing is just you're essentially, and best way to describe it is you're opening up the floodgates, and everything that you're putting in that patient when it comes to blood, when you're trying to clot, those normal saline fluids, when people will usually do it wide open and give a large amount, it's breaking those clots that you just are trying to form. So reducing shock and coagulopathy are two key factors. Step 3, increase survivability by managing these trauma patients and getting them to a higher level of care. So the golden hour is from time of trauma to surgery. The golden hour is anywhere between 60 minutes and 90 minutes. Of course, at times it is difficult because with EMS, if you're having to respond from quite a distance, then it may delay your patient care and getting them to the hospital. But survivability is the best thing to do. If you can get that patient off scene in 10 minutes or less, that's the ideal goal. But if we can get them off the scene and transport within a 20-minute window, their survival rate is still pretty good as long as your trauma center isn't too far away, and then you can get them to the hospital so the doctors in the ER can do their evaluation, and then a trauma surgeon can fix the damage that's been caused from the trauma. All right. So, damage control resuscitation, the vital steps, and these are huge. So, your rapid triage and assessment. Again, this is when it comes into where, let's say you have a motor vehicle collision. You arrive on scene and you see that patient who's in the vehicle. They are need to be extricated from the vehicle by the fire department. If you're able in the vehicle to do safely a rapid triage and assessment, then you can fix life threats before removing that patient from the vehicle. So let's just say an example, if a patient has an arterial bleed from a motor vehicle accident or just any trauma in general, you can easily apply one of those hemostatic agents to the source of bleeding. And if that does not correct the problem, then you can actually apply the tourniquet while the patient is still in the vehicle, as long as, again, you are safe. So that is a part of your rapid triage and assessment. You try to get to that patient as quick as you can to find those life-threatening injuries and fix it as soon as you can. So identifying your patients, that's your number of patients. Going back to what I just discussed with the motor vehicle accident, it could be a single patient in that vehicle who was involved, or you could have up to anywhere between 4 to 6 patients on the scene from a motor vehicle accident. So knowing your number of patients is very vital. That's why when EMS or fire department get there, they do a quick scene size up, and then they do a rapid triage to know exactly how many patients there are on the scene. So with your additional resources, if let's say you do rapid triage in 6 patients and realize that some of these are category yellow or category reds, then what you need to do is you need to request those additional resources, more BLS ambulances, more ALS ambulances, whatever you can get, get them to the scene as quick as you can. Your triage system, that goes back to what I just said, categorizing your green, your yellow, your reds, and your black patients on scene. So your green patients, if you have BLS units coming, they can transport your green patients as long as there's no life-threatening injuries. Your yellow and red patients need to be transported by ALS unless they don't have a life-threatening injury at that point and you don't want to delay patient care and you want to get them to a trauma center as soon as you can. BLS crews like double EMT ambulances can still take that patient because, again, the biggest thing is reducing shock, and they can easily do that by doing the treatment that they need and by doing the simple measures of covering that patient, keeping them warm because you don't want to cause hypothermia to these patients. So prioritize. Remember, number of patients, know where your local hospitals are, your trauma centers, where exactly these patients are going to need to go. Are you going to need aeromedical? Are you going to need additional resources from surrounding counties? It's possible. So that's why getting on scene and doing your rapid triage and assessment is going to be vital. Team member roles. With that, that's where whoever the scene commander is, they can kind of delegate, say, all right, your EMT, you go over there and stop the bleeding on that patient. You may have an advanced EMT on scene. They can do some basic treatments as well. You want to delegate that patient to that one. Your ALS providers are the ones that are going to do more of your extensive type treatments. However, you don't want to stay on scene to do those unless it's something that needs to be fixed right then and there. Example being a pneumothorax or just anything that is going to kill that patient and needs immediate intervention. So team member roles is key, and that's going to come in on scene with your command. It could be the fire department command, it could be medical command, but use what you have on scene. Your vital signs assessment and your rapid trauma. So with these trauma patients, you want to maintain a systolic blood pressure between 90 and 100. Once you start getting below the 80 systolic mark, then depending on the trauma, that's when they may need administration of whole blood, a little bit of fluids. Again, you don't want to overload these fluids with normal saline or lactated ringers. But maintaining that systolic blood pressure between 90 and 100 is key. And that's why you need to make sure you're taking your blood pressures every 5 to 10 minutes on critical patients. Exposing the patient is very critical. That is another way that you can look for life-threatening injuries. A lot of people are against exposing patients on scene, whether it's on the interstates or just on a normal street, because they think it looks bad. However, you're not going to know what type of injuries the patient may or may not have if you're not completely exposing this patient. So, exposing the patient, doing your rapid trauma assessment, looking for those hidden bleeds, and that's why you have to expose that patient on scene. Okay, so the vital steps continued. So as you can see, hemorrhage control. What's the thing that's going to kill this patient? The bleeding out. It can happen very quickly. The patient with severe trauma can bleed out within minutes, depending on what type of injury they have. So hemorrhage control is key. So walking up to these patients, applying direct pressure to bleeding. Use large gauze pads. You can use as many as you want to stop the bleeding. If after direct pressure it's not working, I like to aim for 30 to 60 seconds. If it's not working, you can utilize the resources you have, whether that be in the fire department or your other EMS providers, and you can apply tourniquets to these wounds to help stop the bleeding. You just got to remember with tourniquets, when you get those on there, you want to get it at least a half an inch to 1 inch above the actual wound, the injury, and you want to make sure that when you're tightening that, you're tightening all the way until that bleeding actually stops. And when you're checking a radial pulse, you want to make sure that they do not have a radial pulse anymore. So you can't stop doing that tourniquets until those things occur. Also, people ask, how many tourniquets can you apply? You can apply an unlimited amount. You don't want to apply an unlimited amount as in up to 5, but if you need to apply 2 tourniquets, it's not going to hurt the patient. The key thing, though, is keeping track of the time as to when you put the tourniquets on so you can let the physicians know at the trauma center. Pressure dressings, that goes back to your hemostatic agents directly against the wound. So what you want to do is you press those against the wound tight enough. You want to hold it there for at least a minute or 2, and then you want to take some of your cling or whatever you may have in your jump bag and secure it tightly so the bleeding stops. Your wound packing. This right here is a big thing when it comes to, you're going to see it with your GSWs, maybe your stabbings. If you have a large open wound, you need to take your wound packing, open the package up. You need to put it down there as far as you can until you can find the source of bleeding. Once you do that, then continue the wound packing and then make sure you are placing the initial, whatever you have left, over the top of it and taping it down to make sure the bleeding does not continue. Pelvic binders, these are key, and we'll definitely go over those quite a bit later on in this presentation. But pelvic binders are very important because if somebody has a pelvic fracture, they could easily have nicked an artery, and in order to stop that bleeding internally, you're going to have to use a pelvic binder on these patients. So the key thing here, according to Stop the Bleed National Campaign, uncontrollable bleeding is a major cause of preventable death. Approximately 40% of trauma patients worldwide die because of due to bleeding or consequences, establishing hemorrhage control as the most preventable death in trauma. Average time to bleed out, like I said even before, is 2 to 5 minutes until you can get this bleeding stopped. That's why they do offer classes on the Stop the Bleed. You can actually get certified in this class. And for the general public, this is a great class because when they are bystanders and they notice that they may have some type of bleeding, if they have any type of tools that they could use, they can help stop that bleed. Okay, so now we're going to go over resuscitation. So a lot of systems in North Carolina do not carry whole blood. Onslow County EMS actually does carry whole blood. We started carrying whole blood in 2019. This year alone, we've already gone through 6 units of blood, and it is only February. But whole blood is a lifesaver. It very much is. It's the number one option in severe hemorrhage. With that, you have to You can't just hook it up to the patient. You have to actually have a device where you warm the blood before administering it. Um, some indications for that is, for one, provider discretion. If you believe that this patient with their injuries are going to bleed out fast, then you may not have to wait on that systolic blood pressure of less than 70. If a patient has multiple gunshot wounds and there's something internally that's wrong and they could easily bleed out and die, giving that one whole unit of blood is not going to hurt the patient. Blood pressure less than 90 and a heart rate over 110 gives you that shock index of greater than 1. With your shock index, all you have to do is take your heart rate and divide it by your systolic blood pressure. And if it's greater than 1 per most protocols, that's when you do 1 unit of blood. However, again, with that, it can be a provider discretion. If you know that patient has been, has some type of internal injuries, you can go ahead and give the blood and not necessarily have to rely on that shock index. Your whole blood requires at least a 20 gauge or larger. In trauma anyways, it doesn't always happen, but if you can establish that 16 or 18 gauge bilaterally, that's going to be the best option for the patient for quick resuscitation. And again, I'll say it till I'm blue in the face, warming the patient is vital. So putting that blanket over the patient, cranking up the AC and the heat in the back of your truck. If you're not sweating in the back of that truck, then something's wrong. So our medication administration with the whole blood. So while you're giving that whole unit of blood, which is 500 cc's, you can give it IV or IO. Once it is complete or during it, you can administer 2 grams of calcium gluconate. You have to put it in separate lines though, so you don't want to have your whole blood going in your right AC IV and then connecting the calcium to it. You want to put it, that's why it's good to have multiple lines, so you can give blood on one side and give the 2 grams of calcium gluconate in the other IV. TXA, that's in our protocol, and it is a part of the North Carolina State protocol. Our TXA is 1 gram over 10 minutes. Typically, we are putting that in a 100 cc bag of normal saline and doing it over 10 minutes. Some state protocols are being updated to where it is just 2 grams IV push. And again, limiting the IV fluid to normal saline because you don't want to coagulopathy. You don't want to mess that up. You're trying to get back to that homeostasis. So limiting IV fluids to maybe 250 cc's to 500 cc's is probably going to be your max. So all of our providers that we spoke about before, all levels here in Onslow County, we have EMTs, AEMTs, and our paramedics. When you get that early recognition with our patients and resources needed, then again, that's where our scene command can kind of delegate where they need to go so you can do your proper triage. You can do the triage tags on these patients, or if they're ambulatory, you can have them go somewhere to the side to where they can be evaluated and off of the scene so you can concentrate more on the priority patients. Your aggressive mitigation, hemorrhage control, again, with all the devices that all EMS providers should have, we need to stop the bleed because again, that's what's going to kill you within that 2 to 5 minutes. Airway management, if that can be fixed in the back of your unit, it's the best way to do it. However, if you're on scene and this patient has a severe trauma to the neck to where they're going to have airway compromise, then you might have to be prepared to do a crike on that patient. In your proper transport destination, here in Onslow County, we have a level 3 trauma center, but we also have a level 2 in New Hanover County, and then we have a level 1 in Greenville. So the aggressive treatments, being proactive, not reactive, like I said, bilateral lines, blood, TXA, calcium, and airway management if required. Okay, so you have your stay and play, or you have your scene time less than 20 minutes. Again, your severe trauma patients, the one that are going to need immediate surgery, you want to try your best 10 minutes or less. Do your rapid assessment, stop any life threats, and if there is no life threats, get that patient packaged and get them in the back of your unit and begin transport. Again, sometimes it's not realistic, especially if they're in an MVC and they need to be extricated. But if you still aim for that 10 to 20 minute mark, that's going to be key. Failure to assess appropriately. That's why, like I said, on those interstates and on those streets, you have to expose that patient no matter what. You can always have somebody grab a sheet to kind of cover up the scene so no where you can see the patient. And then overloading the patient with fluids. Again, 250 cc's with normal saline or lactated ringers to 500 cc's max. And your failure to consider passive and active warming. All right, we're going to talk about the trauma triad, which is what we brought up earlier. So coagulopathy, if you can't get that patient to clot with your blood and your TXA, the chance of them bleeding out will probably be possibly a lot faster than the 2 to 5 minutes, depending on the type of injury they have. So getting the patient the blood to clot is going to be crucial. Your hypothermia. Again, this can be easily managed with warming the patient with a blanket and you having the heat cranked up in the back of your unit. Patient becoming acidotic. That's just from the basics of bleeding out from your injuries, your trauma. But giving the calcium gluconate with the blood actually reverses those symptoms and gets that homeostasis to where it'll kind of change the fact of the patient not being acidotic. And also you can help with the acidosis by high flow oxygen. Anything to get oxygen and perfusion to those tissues is what's going to be key. All right. Again, everything that I just spoke about. Once a hypoxia occurs, creating the anaerobic metabolism is where it's going to lead to death a lot faster. Your lactic acid is byproduct. Reduction in pH leads to coagulopathy. And your coagulopathy occurs when enzymes that would initiate clot formation are depleted or the inability to function as present causes. And from that is your inadequate cellular oxygenation, which is your acidosis, your inability to regulate temperature, hypothermia. As you can see, I put in all caps that you need to warm that patient. Hypothermia, as temperature decreases, so is the efficiency of your thermoregulating. You need to keep trauma patients warm, even when temperatures are hot. Blood loss equals heat loss, and drop in core temp decreases the patient's ability to clot. All right, so now we're going to get into the good stuff. This is an incident case study that happened to me in 2019. As you can see right there, you can call it a bulldozer, you can call it a tomcat, whatever you'd like, but that right there is a heavy piece of machinery. So we're going to get that mental image in there of what may be to come with this. Okay, so here's what occurred. Here was the dispatch information. It's for a 65-year-old male, traumatic injury at a local turkey farm. Patient was found laying supine on the ground and was in no distress at that time. The worker on scene was a male, and when he was asked what exactly occurred, what led up to the events, he said that he was on the bobcat and that he bumped him with the track loader. That's all he said. He said he bumped him. So level 2 trauma center was 60 to 90 minutes by ground, and that is New Hanover and Wilmington from where that location was. 20-minute flight to a trauma center. So you have to kind of look into it like that. The weather is air medical going to be flying. But on that day, it was a clear day and it was 70 degrees. So air medical was put on standby, but sometimes they have a delayed flight. So it's always remember to keep that in mind to not stay on scene. Try to at least start heading to your local trauma center, which in that case was a trauma 3. So you can request air medical, but don't wait on them. Have them start meeting you towards the local hospital, your local trauma center. So upon approaching that patient, the visual findings, he had multiple abrasions across his chest, abdomen, and pelvis. So it was more obvious then to my partner and I that he was not just bumped, that he was obviously ran over. He had deformity to both upper extremities. And when the head to toe was done, clothing was removed, and we rolled the patient on his side to do the assessment of his back. We noticed a significant amount of blood coming from his rectum. The fastest thing that we could do there was we took some large abdominal pads and just kind of placed them in that area the best that we could. I mean, you can't put a tourniquet there, so we put a lot of padding on there to try to help control the bleeding the best we could. So the treatment and packaging for that is we immediately placed a C-collar on that patient. We removed him from the turkey barn. That was one of the key things of where we were at. We had to get him out of there. We had placed him in the ambulance and continued to do full exposure of the patient. And we covered the patient again for warming measures with blankets after the rapid assessment. All right, so as the case progressed, this is what we started to find. His initial vital signs were 80/40. He had a heart rate of 124. So right then and there, we knew he had a shock index greater than 1. His respirations were 22. His SpO2 was 90% on room air at that time. We did put him on high flow non-rebreather at 15 liters a minute at that point. End-tidal CO2 of 30, so that's pretty good. So he's still metabolizing. He had a GCS of 15 with no loss of consciousness. Pain was a 10 out of 10, but due to that current blood pressure, we weren't going to administer any type of pain medication, and truthfully at that time that was not our top priority. He did have poor perfusion, weak radial pulses, and he had a weak carotid pulse, and he was cool and clammy. So immediately after doing our head to toe, what we found is that he had a unstable pelvis. So my partner immediately placed a pelvic binder, which all EMS providers should have pelvic binders on their unit. But we placed the pelvic binder on there to help control the internal hemorrhage. We established bilateral IVs. We initiated whole blood with normal saline. Gave him TXA of 1 gram. At that time, we did not have calcium gluconate, but we did carry calcium. So we ended up giving 1 gram of calcium with that blood. With the other injuries that we found on our head to toe, we stabilized them the best that we could. So as you can see there, that's the QuinFlow. That is what we use to administer our whole blood. That little device there that you see right there. If you would have to take it out of the package, but once you connect all the batteries and everything to it, it's got a two-way flow. It'll warm up your blood, and then you can administer it through there after flushing the line with your normal saline. QuinFlow will warm up the blood pretty fast. It needs to be at 36 degrees Celsius before you can administer it. And of course, there to your right, you can see the TXA. Your dose is 1,000 milligrams per 10 mL, so 1 gram is your dosage of your TXA. You want to hang that on one of your other lines would be the best thing to do. You don't want to give your blood and TXA in the same IV site. So preparing that as fast as you can is what's going to be vital for patient survival. But again, you're going to be doing all this en route. You're not going to stay on scene to do this, especially if you have a long transport. Okay. As this case progressed, we began transport to the LZ. The Air Medical said they had a 10 to 12 minute ETA to our local hospital, not the trauma center, but it was closer. So we actually met them at our local ER at their helipad. As we were en route to the hospital, patient became altered more. Blood pressure dropped to 78/30 with weak, thready pulses. At that point, we had only got 100 cc's of whole blood in. SpO2 was 84% on high flow oxygen. We ended up having to, due to him being altered, we actually had to start assisting ventilations with BVM. Upon arrival at our hospital, the aircraft was waiting on the unit. Due to the patient status, assisting ventilations, low blood pressure, poor perfusion, the flight crew made the decision to go ahead and RSI that patient to go ahead and control the airway since they would have roughly a 15 to 20-minute flight to their trauma center. One of the big things is that with RSI and trauma patients, just remember that RSI and severe hemorrhagic shock patients has its risks. If it is deemed necessary, resuscitate first. Remember that patients are more likely to go into cardiac arrest due to inadequate oxygenation or ventilation during the procedure. So that's when it comes to your high flow oxygen, nasal cannula at 15 liters, and your push dose epi is another thing that's key to use. The outcome of this patient was he had a pelvic fracture, renal laceration, rib fractures, bilateral humerus fracture, and a liver laceration. He was actually discharged from the hospital after 5 surgeries and survived. Second case study, we're going to go over vehicle versus pedestrian. So your dispatch information. There's a 30-year-old female, vehicle versus pedestrian. We checked on air medical right away. They had a 15-minute ETA to the scene, which is where the LZ was going to be. It was actually on the beach area. Our level 3 trauma center was 30 to 35 minutes by ground. Level 2 is also 30 to 35 minutes by ground. It was a clear day and it was 85 degrees. So upon arrival, our findings, looking at the windshield, we found the female supine on the ground, multiple bystanders. The windshield actually had the spider web to it. She was hit and then was actually drug under the large SUV about 20 to 30 feet which is what bystanders said. Subsequently, pulled pelvis under the front tire by the eyewitnesses. There was only one patient, so that was our main concentration. The vehicle actually put it in reverse and from the parking space, 10 to 15 miles per hour estimated speed during the incident. So the initial assessment, again, 30 years old, she was wearing shorts and exercise attire because she was running on the beach. She had a visibly large wound to the interior of her left thigh. There were some military personnel on scene that were off duty. They were holding direct pressure in the upper direction. EMS had not made it on scene. There was a significant amount of pooled blood. They actually applied tourniquets for the patient to help stop the bleeding. Our treatment when we got there is we did direct pressure and during packaging the patient to get in the back of the unit, placed our cervical collar on the patient to protect her spine. Immediate removal from the roadway. We placed the patient in the ambulance for full exposure to look for any other life-threatening injuries. So as the case study progressed, these were her vital signs initially. She had a blood pressure of 80 systolic, which was confirmed multiple times by myself, my partner, and the fire department. Her respirations were 20 to 24 a minute. SpO2 was 95% on room air. GCS was 15 with no loss of consciousness. Her pain was a 10 out of 10. She was screaming. It was very difficult to assess this patient because she would not stay still for us. But for our interventions, what we ended up doing in the back of the truck was we did direct pressure to the wound, controlled the bleeding adequately. Again, we used that pelvic binder for unstable pelvis. We did bilateral 16 gauges on this patient for IVs. Supervisor arrived on the scene and immediately initiated whole blood. And then we gave a 250 cc normal saline bolus with that as well. And we administered our TXA 1 gram over 10 minutes. Once the patient's blood pressure started to come up, we did give small amounts of fentanyl to this patient to help control that 10 out of 10 pain. But again, when you're giving pain medication with these patients, you have to be very careful not to drop the blood pressure. Good thing is fentanyl is a very safe pain medication, but we're not going to give it if that initial blood pressure was 80 systolic. You got to get that blood pressure at least over 100 systolic before you want to administer pain medications. All right, so transports. There's a 22-minute patient contact and treatment time. The aircraft arrived on scene and care was transferred 24 minutes from initiation. Again, you want to stay within that 10 minutes mark, getting them off scene. So, but we were roughly around that 20-minute mark. But again, that 10 to 20-minute time frame is what you want to stay with. You don't want to be delayed any more than 30 minutes on scene with a significant trauma like this. The pressure upon patient contact care was almost 90 systolic. It was actually 88 over 54. The report that we got back from the hospital was she had a hepatic laceration, a renal laceration, bilateral pelvic fractures, multiple rib fractures, and she had a laceration to her thigh with an avulsion, but there was no arterial involvement. So as you can see with these two case studies that I presented to you, I spoke about pelvic binder and how it was utilized on both. It is a vital tool that as providers that we carry, whether it is a bed sheet, especially in our geriatric patients, or EMS issued binders, is important that it is applied prior to the patient reaching the hospital to control that internal bleeding. A pelvic binder compresses pelvic structures, and this encourages any blood in the pelvic cavity to clot, reducing any further bleeding. Binders do not control arterial bleeding and are contraindicated for open fractures. So if a patient has a pelvic fracture and it's open, then you are not wanting to place that pelvic binder because you will actually cause more damage. These are for pelvic fractures that we can actually find when we're doing our head to toe. So pelvic binders, you can see that picture right there. Those are typically the picture on the left, the pelvic binders that are EMS issued. SAM splints is what they typically are called. As you can see exactly where that's placed on the right there. You got too high, too low, and just right. You want to go directly over the iliac crest. That is going to be the safe way to apply that so you can put that on the patients. You put it too high, it's going to cause negative outcome, and same if it's too low. You're not going to be doing anything for that patient if you're not placing it properly. So keeping up with your protocols and training is going to be very vital for all EMS personnel to do to learn how to put those pelvic binders on there correctly. All right, and so here are some of the references that I used. So what I want to do now is I want to I have some expired TXA, which I know it's kind of hard to see, and then an expired bag of normal saline that I'm going to use as well. This is just to show a good presentation on how to draw up our medications. I do not have any gloves on me currently, but that's okay. Okay, so again, TXA comes packaged 1,000 milligrams equaling 1 gram, which is 10 cc's. So here, as you can see, I have a 10 cc syringe. So for people who don't know, you want to draw that up past your 10 cc mark. You want to make sure you're wiping the top of your bottle. All right. So I'm going to put that to the side. This right here is a 250 cc bag, but for training purposes, we're going to say it's a 100 cc bag for our TXA. Okay, so once you have your bag and you have your TXA drawn up, you want to be very safe, and you want to go ahead and put the TXA into the actual bag. And once you remove that, always make sure that you are locking this right here, because you don't want to poke yourself. You want to kind of turn the bag back and forth a little bit, and then from there what you want to do is you want to spike your bag. We use pumps here. We use the Braun pumps. So what I would have to do is I would have to actually connect this, set it up on our pump, and with your TXA, again, you have to do that over 10 minutes. You don't want it doing any faster. TXA is a very safe drug, but you're not wanting to do that. So it's 10 mLs every single minute. With 100 cc bag, they'll give you your 10 minutes. You want to make sure you're putting tape over these bags with the time that you start it. is we do have a short transport to your local trauma center, or if you're switching patient care to air medical, then they can know when the TXA was started, because getting that first gram on board quickly is going to be vital, but typically the hospital will give a lot more TXA. And one of the big contraindications that people don't know with TXA is that you do not want to give this if the injury is greater than 3 hours. It needs to be under that 3-hour mark, but we're not usually giving the TXA in trauma patients a delay like that. We're not going to be with the patients long enough to do that. So the faster we can get this on board, it's going to be better for the patient, because again, the TXA with the clotting factor is going to be vital, and then our blood is going to be the number one lifesaver. So that's why it's good that systems will hopefully in North Carolina, every system will carry whole blood eventually, because with studies and just from general experience, patients that get 1 unit of whole blood, their survival rate is a lot better. You're getting that first unit of whole blood on, you're giving your calcium gluconate, your TXA, minimal fluids, and we've had positive outcomes with these patients. And plus, it gets them the surgery. And once you get them to the trauma center, they're going to be administering a lot more whole blood. So again, to go back to what I said before, the book says and protocols say if they have a shock index greater than 1, you need to administer it. But if you know their injuries are going to need blood, you do not want to hesitate to give that 1 unit of blood to the patient. But so you want to do your whole blood, your TXA, your normal saline, and keep that patient warm, and make sure that their blood pressure is staying above that 90 mark. Even if it gets to the systolic of 130, that doesn't mean you want to continue to just give normal saline or lactating readers, which is a big problem today in EMS, is that people just want to overload patients with normal saline. And again, that defeats the whole purpose of the coagulopathy with the triad and everything. So limit normal saline, hang your blood, give your TXA, monitor your patient, doing blood pressures every 5 minutes. Do your focused assessments on your patient to make sure there's no other new injuries, especially looking for any type of ecchymosis, any other type of possible fractures that you maybe didn't feel on that rapid assessment, so you can stabilize every injury that you can before you get to the trauma center. So with that in mind, I hope you enjoyed my presentation today, and make sure that you follow your state protocols and your local protocols and review your damage control resuscitation. Thank you.